Hello and welcome everyone in today's nursing webinar session. Myself, Shanti Bhattacharya, the Vice President Nursing, and will be your moderator for today's session. As you all know, this month is being observed as a Healthy Heart Month, and we have initiated the cardiovascular nursing series. So we are just talking a lot of preventive aspects of it in terms of cardiovascular health. So I think Dr. Vijay Purohit is busy. He's from Hitec Yashoda Hospital, and he'll be joining us with very shortly. And let us welcome the very passionate learner and dedicated and very enthusiastic nurse manager from Yashoda Hospital, Secunderabad, Miss Kalpana. I welcome you, Kalpana. So now we can start the session. Sir will join very shortly. Start sharing the slide. Kalpana.
Yes, ma'am.
Go to the second slide. Yeah, as we all know, what is CVD? CVD is cardiovascular disease burden. This is one of the foremost single cause of mortality, accounting for nearly 7 million deaths and 129 million disability adjusted life years annually. Next. Yeah, you can go with the rest of the session. You can take over, Kalpana.
Okay, ma'am. Let's discuss about cardiac catheterization. Cardiac catheterization is done to diagnose and treat heart conditions. Coronary angiogram is one of its technique. Cardiac catheterization performed by interventional cardiologist and a team of cardiology associates, assisted by in-charge nurse, senior nurse, and technicians in the Cath Lab.
So here we request all the nurses across that they should follow patient safety goals very, very strictly. It consists of right from the identification of the patient until the patient is being signed out from the Cath Lab and comes to the ICU or pre-cath unit. Do no harm is a very significant parameters we all should practice. Continue. Next.
This is a Cath Lab. We have to follow strictly aseptic precautions. What is cardiac catheterization? We see abnormalities of coronary arteries, heart chambers, valves, and major vessels. It is invasive daycare procedures done in Cath Lab. It's done under local anesthesia if required sedation is given. Procedure time 15 minutes to 1 hour. Depends on patient condition. It's done via 2 routes. See the images, transfemoral artery, transradial artery. The femoral artery provides a more direct route to the heart. See the indications for diagnostic purpose, therapeutic and treating congenital heart defects. Determine the need for further coronary, peripheral, and EP interventions. For example, PTCA, TAVR, TMVR, BMV, PVBD, pacemaker implantation, EPS plus RFA. ACS like unstable angina, NSTEMI, STEMI. Also for taking myocardial biopsies. Contraindications. Pregnancy, hypersensitivity to contrast, severe systemic infection like sepsis, acute GI bleeding, severe hypokalemia below 2.5 milliequivalents per liter, INR more than 1.8, acute kidney injury. Let's see what is the responsibility of pre-op nurses. Keep patient NBM for 6 to 8 hours. Patient can be given light breakfast in the morning. Informed consent is properly signed. Pre-angio panel, RBS, CBP, creatinine is must. PTV ECG, chest X-ray, blood grouping, viral markers, 2D echo, printed report should be available. Part preparation, radial, femoral, to be prepared, use tremor only. Insert IV cannula 20 gauge in the left hand. If creatinine above 1.5, IV fluid, normal saline should be started 6 hours prior to procedure if contrast is used. Patient to empty the bladder before shifting the Cath Lab. If expecting a prolonged procedure, Foley's catheter to be placed. In complex procedure, make sure anesthesia team is informed. In complex cases, make sure we have adequate support nurse available. Artificial dentures to be removed. Document height and weight to calculate the dose of dye.
So here we like to request all the nurses across that creatinine blood sample for the creatinine is very important. Do not check the patient without having the printed report available for the creatinine, because we use the contrast medium, and consultant will always check for the report, and then only we can shift prior to that. So this is a very mandate check. Next.
Drugs administered as per written order, cross-check before giving the medications because it is a high-risk medications as ecosprin, frasugel, clopidogrel, heparin, atorvastatin.
So these are very high-risk medications. So one should always cross-check and then only administer. You have your nurses, nursing in charges available, and especially to be cautioned about when you administer unfractionated heparin, which comes with 25,000 international unit and 5,000 international unit as well. So one must be very ensured that we should have a cross-check policy in place. Next.
That is immediate care by ICU nurses. Monitor the patient vitals. Example, heart rate, rhythm, respiratory rate, saturation, blood pressure frequently. A frequency check should be every 15 minutes for first 2 hours after the procedure, and every 30 minutes after 2 hours till 6 hours, then every hour thereafter. Followed by extended care, bed rest for 6 hours, nasal bend move, apply the pressure to the insertion site, observe the catheter site for bleeding, swelling, hematoma. Provide a bedpan, urinal while patient on bed rest. Record 12-lead ECG immediately after receiving an ICU. Make sure resuscitation equipments like defibrillator and intubation sets are ready and in good working condition. Check peripheral pulses in extremity every 15 minutes. Start diet as per order. Encourage for oral hydration and or administer IV fluids as per LV function. Discharge patient as per consultant instructions.
So before giving IV fluids also, you need to always cross-check. You will have your 2D co-reports available with you. So you can always check the LV function, and almost every time our doctors are 24/7, they are nearby. So you can always check, and these resuscitation materials should be always available. You can see the defibrillator, it should be always on, kept on the Joules mode, and you can always administer or provide shock when it is indicated. Your resuscitation trolley intubation material should be readily available, because the post-operative event should be, patient can, have any kind of symptoms. Yes. I think Kalpana, the Dr. Purohit is going to be joining us. In that case, we will tell you. Yes, you can continue.
Sometimes patient develops observed vasovagal signs like dizziness, blurred vision, sweating, hypotension. The time the nurse should act quickly and notify the doctor. Check the vital sign and start IV normal saline and give injection atropine stat. All nurses should be ACLS trained.
Yes, just a minute quickly. I think Dr. Bharat has joined us, and so kind about that you had to just rush up after your patient emergency intervention. It is my tremendous honor to introduce our expert panelist, none other Dr. Bharat Vijay Purohit, who is our senior consultant interventional cardiologist and a very passionate and great mentor, and whose marvelous credential and his achievements cannot be described. I have seen him very closely whenever I see or followed his rounds with him. He teaches the nurses, like maybe it is a air in the IV catheter, or maybe functioning of syringe pump, or maybe right from the draft of the PPT until now. So I welcome you, sir. It is our great pleasure to have you in this forum. I think Kalpana has already dealt with 15 slides. I think, Kalpana, you must go back to the second slide quickly because we will start whatever we wish to learn from Sir. Yeah, yes. So, Sir, we were talking about the CVT burden, and I think 15 minutes we can just modify by asking few of your insight. Like CVT burden is already almost, it is a foremost killer disease. Are we able to mitigate the risk prevention? Because it is one of the nearly, foremost killing disease in India.
Are you able to hear me, Shanti?
Yes, sir. Yes, sir. You're audible.
See, these are all non-communicable diseases, whether it is hypertension, whether it is diabetes, whether it is cardiovascular disease, or it is
Yes, sir.
cancer. These are all non-communicable diseases. So if we have to reduce, we are not even thinking of eradicating. We are thinking of reducing the burden. And what we are seeing is that day by day, the cardiovascular burden is increasing
Yes.
in developing societies, especially like India, which are low and middle income society. If you take compare it with the Western society, which is so-called developed society, there, because of the advancement in the treatment protocol as well as the awareness in the society, we have been able to prolong the life. But when it comes to reducing the burden, even then also they have not been able to reduce the burdens because it's mainly lifestyle related. What
Yes.
we eat, what we think, that is
Yes.
the stress level, and
Behavior.
how much activity we are doing, what kind of food we are eating, and how we are sleeping. So all these factors are contributing, and you see as the more and more we go into Western lifestyle, the more is the stress level. We don't eat well. We don't. You can see right now, I was just doing a procedure and then I had to rush in here. So, so that also adds to a stress, right?
Yes. Yes, sir. Yes,
How much
sir.
we say it is there or not there, but it is always there.
Always there. Yes,
So
sir.
that's the whole thing. The whole idea is, if on one hand we have to look at the lifestyle modification to reduce the burden, and at the same time we need to focus on the treatment part, which is secondary prevention, where we give them proper care, and we give them the best care so that the patient goes out of the hospital in a proper way. And there are very, very small things which are required. And treatment is not just a responsibility of the doctor. It's the whole hospital which is responsible for the treatment, which includes starting from the safai wala who does the cleaning part, as well as the support staff who the cook, the dietitian, the place where we are cooking, which brings the food material to the hospital,
Yes.
the engineers who are taking care of how the infrastructure part of the hospital, the housekeeping boy who is cleaning the floors, which includes a lot of antiseptics, and
Yes.
they are
Yes.
also an important and the two major pillars who are actually directly involved with these are the indirect people. The
Yes.
direct involvement comes with the doctor and the sister, and the doctors are associated with the patient hardly for 15 minutes or 20 minutes in 24 hours. But it is the nurse which is the main pillar, who is there with the patient day in and day out for almost 24 hours. The sisters are there. So the responsibility of the sister in taking care of the patient is you can say, if I see say half an hour, and then you make it 24 hours. So you can imagine how many times the responsibilities of the sisters. So the small things which we take care of, they have to be given importance, and that is the whole purpose of these lectures.
Yes.
That we have to make the sisters aware about what needs to be seen, and when should they alert, what are the
Yes.
earliest signs, what are the complications which can happen. If they are aware about the complication, they will see it. If what we don't know, we cannot see it.
Yes.
So
So
eyes cannot see what the mind doesn't know. I think that's
Yes.
a famous proverb we all know. So the whole idea is to make sure that the sisters, they know what needs to be seen after a patient from the cath lab, and so that they can alert the doctor of any possible complications, and they can take care of the patient and give appropriate treatment to the patient. So that's
Yes.
the whole purpose of this lecture series. I think it was a wonderful thing. So let us go ahead and listen to what Kalpana has to say.
Yes. Forward to have more inputs from you. Kalpana, just go to the third slide. Let us see what we have in the third slide. Third, yes. Go on. Fourth slide. Yeah, next, please.
Let's discuss about the
No,
cardiac.
no. Go to the fourth slide.
No.
Don't repeat these slides because we are going to have sirs inside now. Yeah, fifth. Keep moving the slides. Yeah. Yeah. So here, sir, we would like to know, like these are all indications, and I'm sure, and thanks to you also that you have corrected me the other day for the indications, parameters, recorrections and all. Why the EP interventions, when we see a patient comes to you with XYZ complications or conditions, can we do EP study before cardiac catheterization, or how it is? We nurses, we would like to know.
Basically, you want to know what exactly is EP study and RF ablation, right?
What are the indications, or whether should we should we only do with EP condition, and then my condition has been diagnosed, or I need not to go for cardiac catheterization.
Yeah.
This is this insight about.
Before I go into the last word, that is EPS and RFA, let me just understand how many of you they know what is a TAVR, what is a TMVR, what is a BMB, because there are a lot of short forms going on here. So are you all familiar with these words?
Yes.
Kalpana,
Yes.
do you know all these things?
Yes, sir.
Can you just tell me what is a PVBD?
Pulmonary wall balloon dilatation.
Yeah, excellent. So you are all aware. So just for the people who do not know, because I think it's a seminar for all. So TAVR is transcatheter aortic wall replacement. TMVR is transcatheter mitral wall replacement. So nowadays we are able to replace the aortic valve and mitral valve percutaneously by going through the femoral artery and femoral vein. And then we come to the thing which is called as a pacemaker and EPS and RFA. So basically, we have to understand the word catheterization. Catheterization means, it's inserting a catheter. So you use urinary catheterization when you insert a urinary catheter into the bladder. So same way you call it as a cardiac catheterization when you insert a catheter or a pipe into the heart. So what exactly is EP study? EP study is an electrophysiological study. So electrophysiological study means we are trying to assess the electrical activity of the heart.
Yes.
What does the electrical activity do? It makes the heart beat.
Yes.
Now, if somebody has an abnormal electrical activity, then we do this electrophysiological study. What are those abnormal electrical activity? The moment you have an abnormal electrical activity, you will have an abnormal heart beating. So your patient will have irregular heart beating.
Yes.
So we have various types of irregular heart beating. Patient can have a VTVF, which is the most common, which we see in the ICU, where the patient can die. The patient will have suddenly has a cardiac arrest, and you put a defib monitor. You say, "Sir, patient is having a ventricular fibrillation or a ventricular tachycardia." Or the more common ones are the atrial fibrillation, where you have a irregular heart beating and patient comes with palpitation. And sometimes these patients can develop brain stroke because of some blood clotting. Or the most common one is the PSVT. The patient suddenly has a heart beating of say 180 or 200, and you do a ECG, you see that, and the doctor tells that is a PSVT. That means paroxysmal supraventricular
tachycardia. Yes.
So these are all abnormality of electrical activity where the heart beating becomes fast.
Yes.
There are situations where the heart beating can be slow also. We call them as a bradyarrhythmias, like somebody has a complete heart block, or somebody has a sick sinus syndrome, or somebody has a 2:1 AV block. So these are various heart beating where the heart beating is low. So if the heart beating is low, we don't do a EP study here, because we know the heart beating is low, and the only treatment is we need to put a pacemaker which can increase the heart beating. For fast heart beating, patient who has got an irregularly and abnormally fast heart beating, we do an EP study. EP study is mainly to find out where exactly the fault is lying, which is making the heart beat so fast. Either the electrical activity is so confused and
Sir, don't mind, keep your mic little closer.
Yeah. Is it okay now?
Yes, sir.
Yes.
So when you have a fast electrical activity, you need to find out where is the source. Either there may be a abnormally fast pathway through which the impulse is going, so that is why it is rapidly transmitting into the ventricle and making the ventricle beat faster.
Bit faster.
That is the most common cause of PSVT. Second electrical activity, abnormal activity is a VT, which we all commonly know. So we
Yes.
need to know from where the focus which is arising in the ventricle, which is making the heart beat faster. So it is an abnormally high activity focus in the left ventricle. Normally the ventricle should get activated only by an impulse coming from the atrium. Here
Yes.
there is an abnormal source which is abnormally firing, which is located inside the ventricle. So it may be in a patient who has got a heart attack, or it may be because of some myocarditis, or it may be suo moto. There may be some abnormal focus which is happening in the ventricle.
Yes.
So
Go to
these
the
are
next slide.
situation where we find the electrical activity is fast, and we do a mapping. So
Yeah.
mapping can only be done by inserting a catheter inside, and that catheter will have sensors, and these sensors will tell from where the electrical activity is happening. So the moment you have entered into the heart, we call it as a catheterization. So that is why a catheterization is a part and parcel of EP study. It cannot be done from outside by keeping like an MRI or CT. It has to be done by going inside the heart. That is why it is taken as a part of cardiac catheterization. We have inserted a catheter into the ventricle or the atrium, and we are trying to map the whole electrical activity of the atria and ventricle and finding out the source from where the abnormal activity is happening. And then we are trying to ablate that so that the
So-
focus is removed and the patient is cured.
So it is one of the invasive kind.
Yes.
Yes.
Without entering the catheter, you cannot do a EP study.
We cannot, yes. So when we were talking about the contraindications and we were just looking at the pregnancy, here we would like to know until which of trimester, if a pregnant mother has some heart abnormalities, where she can go for, cardiac catheterization, until which trimester? And what safety precautions we need to take?
See, generally, if the person is first or second trimester, generally we have to be extremely cautious because these are all involving radiation. So
Yes.
any radiation exposure is contraindicated in pregnancy, even up to the third trimester. But if it is extremely necessary to save the life of a patient, like take for example, patient has mitral stenosis, severe mitral stenosis,
Yes.
which went undiagnosed, and you are diagnosing the mitral stenosis in second trimester. So you have to do something to make sure that the baby is delivered properly, as well as the mother is also safe. Otherwise, because of the increased volume, patient will go into pulmonary edema and heart failure.
Yeah.
So in that scenario, you have to do a catheterization and do a BMD. So here you have to put a lead silt to protect the baby. So all this has to be done beyond second trimester. In first trimester, you are not supposed to expose the baby to any kind of radiation. So it is absolutely consideration in first trimester, and in second and third trimester, with limited precaution, you can still do it.
Yes. Next slide, Kalpana. Yeah, so we were talking about the pre-operative nurse's responsibility. I think these points are very fine, and we have stressed, for taking the creatinine report, printed report available so that, procedure goes uneventful. Yes, next slide. I think you have also given us a lot of update about high-risk medications and the loading dosages, when to give and how to give all that. And I think everybody should check and give. Next slide. Yes, sir. This I think immediate care by ICU nurses, this frequency, I think this frequency for 24 hours is very mandate, sir.
Yes, basically, it is not just for this patient. If you
Yes.
follow this simple procedure for anybody who is coming to your ICU, you just have to focus on three important aspects. One is his heart rate, one is his blood pressure, third is his saturation level. Just focus on these three things. You will be able to prevent a lot of things.
Yes.
Don't wait till the patient goes into a cardiac arrest. You must pick up the patient when you start seeing the trend. Like what do you mean by trend? I have made it a simple formula for everybody, that any patient, after receiving the patient, you monitor his pulse, blood pressure, and saturation level. Any 10 change in thing, like if the blood pressure goes up and down by 10, if the heart beating goes up or down by 10, you must be cautious what is going on. And you should keep checking the patient continuously, that okay, when the patient came, the heart beating was 120, or the heart beating was say 80, and now the heart beating has become 70. Why did the heart beating become 70 within a span of 15 minutes? Why did the heart beating become 90 in a span of 15 minutes? What happened? Why,
Yes.
when the heart beating was 120, why did it become 130, or why did it become 110? So any change in parameter of 10, in terms of heart beating or blood pressure. If the blood pressure was 140, why did it become 130? So that should immediately alert. So this is what I call as a rule of 10. You keep checking and you should note down the moment there is a change in 10 millimeter mercury, and you should be alert and aware that, okay, something is going on. If you are careful and if you monitor, you will see that this change will again revert back to normal in next 5 to 10 minutes time. But if it doesn't become normal, and if you see that is going down from 90, it has come to 80, and then it has become 70, then you must alert your doctor. Doctor, I don't know what is going on, but the heart rate is falling. It is still within the normal limit. The patient has not gone into a cardiac shock situation or not gone into arrest situation, but you need to pick up the patient before he goes to that. If you see that the blood pressure was 140, now it is 130, and now it is 120, why the BP is going? You cannot wait for the BP to become 90 before you alert the doctor. Because the moment you pick it up at that stage, we can do an invasive assessment, either by a 2D echo or by assessing the groin or by doing an ultrasound, and we can pick up a early bleeding response in an early stage and prevent it. If the heart beating is going, like, there are two things. One is most common is a vasovagal, and another is a hypotension due to the volume loss. There is a bleeding somewhere. If there is a vasovagal, there will be hypotension with bradycardia. If there is a volume loss, there will be hypotension with tachycardia. So those things can differentiate what is going on.
So I think very great to hear this rule of 10 acronym, which you have developed for preventing the early warning escalation parameters. Thank you so much for that. And as we have already discussed, vasovagal and all the nurses should be ACLS trained, and one should act very quickly. Next slide. So we were talking about the rarest complications, sir. I think post-cardiac procedure or post-coronary angiography or gram, the dissection or tear, are these the complication are common, or it is the rarest, and is it for the short term?
No, these are all pretty common complications. If you see at the allergic reaction, bleeding, bruising, pain, abnormal heart beating, urinary retention, these are very, very common. They happen very frequently in the ICU. I've seen a lot of patients, the moment you remove that dynaplast, they'll have a skin peel.
The skin peel,
So we cannot be careless by doing that. I still remember there was one patient whom I was doing a procedure, and I asked the sister for giving me a scalpel. And I was looking at the monitor, and the sister was also looking at the monitor, and she gave me the scalpel and just dropped it. I had not held the scalpel, and that scalpel went straight vertically down into the thigh. And it took 2 months for that wound to heal. Just a simple thing of alertness and lack of communication between me and the sister, it created so much of trauma to the family for almost 1.5 to 2 months. Similarly, you remove the skin peel. See, nothing will happen, but you imagine the psychological impact this gentleman will have, that I went for a simple angiography and I'm coming back with a wound. He will not have a good impression about our hospital. That impact will last, and next time if you tell him to do an angiography, he will not agree. That I had a bad experience with angiography, and he will tell others also not to undergo. Suppose if he has got a lot of pain, he will have a very bad impression about the angiography or a catheterization. Oh, it was so painful. Don't ever go for an angiography. It's a hell of an experience. So these are all psychological aspects which we need to understand, and it has got a huge implication in the society. What kind of message they are going to convey about our hospital? If they go smoothly smiling, oh, I went, this sister gave me an injection, I didn't even feel where she gave an injection. You imagine that response, and you imagine another sister giving an injection. Oh my God, this sister kept me poking me here and there, and she still could not find a place from where to give a vein. So these are small things, but they have a huge implication about the reputation of the doctor, the organization.
So those errors, I think we all must be very careful about it before we do the intervention, and we should not repeat, or it should not even reoccur. Next slide, Kalpana. Next slide. I think we have come to the prevention and nothing but conclusion. Conclusion still we would like to hear from your part. But I think prevention, protect your heart disease, no smoke or use of tobacco, aim for at least 30 to 60 minutes of exercise, be in a not of state of inactive state, eat hard healthy diet, aim for healthy weight, have adequate rest and sleep, manage stress, As I can see, sir also coming with a lot of stress because he had to log in for the webinar. I'm so sorry about it. And have a regular health screening so that you can mitigate the risk before it attacks to your heart. And we would like to hear from you the two-line conclusion part, and then we are done with the end of session. Yes, your message.
Just two lines for the entire sister community is only thing is that enjoy what you are doing. Don't get stressed out.
Yes.
If you enjoy your work, you will never feel any stress. The stress comes when you don't enjoy your work and you feel that it's a burden on you and you have to just finish it somehow and go. No, it's a big responsibility which is there with you.
Yes.
And taking care of a person is a privilege which we have got. No other person in the world has got it. The patient has surrendered completely to us. So we must take care of him in that way. We should feel that he is like a tender small baby, and that's how we need to treat him. A patient is always like that. The way you handle a small baby in your arms, same way you need to handle the patient with love, affection, and care. And don't get stressed out, because the people who are coming to take care of him, the doctors, the in-charge nurses, including Shanti Menon, they are undergoing tremendous stress taking care of the administration part. So that all stress many a times comes out on you all. So you have to understand our state of mind. I used to tell my fellow friends one word. Whenever a professor used to come and shout at us, I used to tell him, don't go into what he's telling. Just understand that probably he had a bad day at home. Probably his wife must have shouted at him. That's why he is behaving like this. Just ignore it. And later on, after half an hour, you see he'll be all right. And 99% time that was correct. So whenever somebody is shouting at you without any reason, just feel sorry about the person. Or maybe something has gone wrong with that person. That's why he's behaving. He's not like that. So let us give him that benefit of doubt and enjoy.
So managing the work style and the stress is very important. So thank you, sir, for your great input. And I like the way you have described the rule of 10. And I'm sure we all will be practicing it. Thank you. And thanks to you, Kalpana. And we end the session. Next week also we'll continue with ACS management. Thank you, sir. Thank you, Kalpana.
Thank you.